Professor Hatkoff, I'd like to thank you for the invitation to come again to Moscow and to meet many of your colleagues and friends and talk about my favorite topic, and that is the Whipple operation. I'd also like to thank Dr. Ruslan Alekhanov, who was nice enough to come and pick my wife and me up at the airport a couple of days ago. He visited our unit in 2003 and spent 3 months there. And then I saw him again in Geneva, so it was nice to see him again here in Moscow. And I'd like to thank, again, Dr. Hatkoff and Ruslan for being such gracious hosts. Now, I want to talk a little bit about the history of the Whipple procedure. And I want to start with talking about William Stewart Halsted. I don't know whether that's a name that you're familiar with or not, but in the United States, he's considered the most important, innovative, influential surgeon that the United States has produced. He was the first chief of surgery at the Johns Hopkins Hospital in 1889 when it opened. And he introduced a residency training program into the United States. Before that, if you wanted to be a surgeon, you had to be an apprentice to someone who called himself a surgeon who also had no formal training. So with Halsted introducing the residency training program in the United States, really the modern era of surgery began in the United States in 1889 with Halsted. Now, in addition, he made many contributions to surgery. He and Bassini devised the first effective operations for the cure of inguinal hernia, the Halsted radical mastectomy for far advanced breast cancer was the operation done really around the world for many, many decades after he introduced it. He visited Bill Roth in the late 1890s and early 1900s and saw that half of Bill Roth's intestinal anastomoses leaked and caused peritonitis, and the patient died. And Halsted was the first one to demonstrate that instead of putting the sutures in the muscular layer, like Bill Roth did, they should be put in the submucosal layer. So he introduced really the first successful intestinal suture. He did the first common duct explorations in the world. He worked out the pathogenesis of gallstone pancreatitis with OPI. He was the first to ligate a subclavian aneurysm and later resect it. He made many contributions, but in addition, he was the first surgeon in the world to successfully resect a periampullary tumor. He operated on a 58-year-old woman who was jaundiced in 1898. He thought she had a gallstone, so he opened up the common duct, and instead of finding a common duct stone, he found an ampullary cancer. So he resected the second portion of the duodenum, the end of the bile duct, the end of the pancreatic duct, and then anastomosed all structures together. And the patient survived the operation, but her jaundice persisted. So 3 weeks later, he reoperated on the patient, and apparently the patient had a stricture at the bile duct anastomosis. So he swung the gallbladder down to the third portion of the duodenum, the jaundice cleared, and the patient was discharged from the hospital. And that's the first successful resection of a periampullary tumor. Now, the same year, in 1898, Cordovilla, an Italian surgeon, also did a limited operation in a 46-year-old man. And he did a resection, again a limited resection, for what was probably a distal bile duct or an ampullary cancer, but unfortunately the patient developed a pancreatic fistula on the 5th postoperative day and died about 3 weeks after surgery. The first successful regional resection of a periampullary tumor was performed by the German surgeon from Berlin, Kausch, very famous surgeon, in 1909. And when the patient survived for 3 years, he published it. So that's the first successful regional resection, the first pancreaticoduodenectomy performed, and it was performed in 2 stages. Now, this is a picture. Andrew Warshaw is on the right. He's a prominent pancreatic surgeon from the Massachusetts General Hospital, and that's me on the left. We're in Berlin, and we're paying homage at the hospital, the Krankenhaus, where Kausch did the first pancreaticoduodenectomy. Now, the operation was done only rarely until the 1930s, when the New York surgeon Whipple and his colleagues reported at the American Surgical Association, the most prominent meeting of the year in the United States, 3 patients, all with ampullary tumors, that they had done limited pancreaticoduodenectomies in 2 stages. This is the diagram from their article, which appeared in the Annals of Surgery. In the first operation, he swung the gallbladder down and anastomosed it to the stomach to decompress the biliary tree, and did a gastrojejunostomy. And in the second stage, he did a very limited resection similar to Halstead's, taking out the second portion of the duodenum. And that was the first really successful small series of pancreaticoduodenectomies reported. Now, the first 1 stage was reported by another surgeon from Hopkins, I. Ridgway Trimble, in 1941. And again, he resected an ampullary tumor, but he did it in 1 stage. And this is the reconstruction. He put the biliary tree back into the jejunum. You see, he left the gallbladder in. He had done a hemigastrectomy and a gastrojejunostomy. He just closed the end of the pancreas without reanastomosing it. That was the first successful report of a 1-stage pancreaticoduodenectomy. Now, the operation evolved over the next couple of decades. So by the 1940s and 1950s, when one talked about doing a Whipple procedure, one was really talking about doing a hemigastrectomy, taking out all the duodenum, the proximal jejunum, the neck, the head, and the unsnate process of the pancreas, and the gallbladder and the distal biliary tree. And even though there are many ways to reconstruct such a patient, either an end-to-end or end-to-side pancreaticojejunostomy, an end-to-side hepaticojejunostomy, and then the gastrojejunostomy was the most common reconstruction back in the 60s and 70s. Now, we do pylorus preserving in about half the patients at our institution, and a classic Whipple in the other half. Now, in the 1960s and 1970s, the hospital mortality in the United States was between 25 and 30%. It was very, very high. 1 out of every 4 patients who had a Whipple died without leaving the hospital. And of those fortunate enough to survive the operation with pancreatic cancer, the 5-year survival in most series was 0. In the best series, it was about 5%. So it was a terrible disease to have, and the treatment that we had to offer was not very good. Now, this is what happened at Hopkins, and I think the same thing has happened in high-volume institutions around the world. You can see in 1969 to 1980, for 1 of the 4 periampullary cancers, head of the pancreas, distal bile duct, ampulla, or duodenum, just for those 4, we only did 17 at Hopkins in the first 10 or 12-year period I have listed there. None of them were pylorus preserving. We lost a lot of blood, 3,000 mLs per Whipple. We had to give 6 units of blood. The operation took a long, long time, 9 hours, and you can see the mortality at Hopkins was the same mortality as around the country. It was 24%. In the early 1980s, we started doing more Whipples. We started doing some pylorus preservations. We started losing less blood. We still needed 4 units of blood to transfuse. It still took a long time, but the mortality was starting to drop. Now, when I became chief of surgery at Hopkins in the middle 1980s, we started concentrating on the Whipple operation and pancreatic cancer, and in that time, we've done 3,800 Whipples for one of the 4 periampullary cancers. If you consider all the Whipples that we've done in our institution up until the present, we've done about 6,000 for islet cell tumors, IPMNs, others. But for just the 4 periampullary tumors, we've done almost 4,000. About half of them pylorus preserving, the other half classical. You can see we still lose a little bit of blood, but the median number of transfusions now is 0. It still takes a fair length of time, 6 hours, but the mortality has dropped precipitously down to 1% from where it was a couple of decades earlier in the range of 25%. Now, the reason for that is primarily volume. You can see in the 60s, 70s, early 80s, we never did more than 10 Whipples a year. But starting in the 80s, we grew up to 100 and then 200. In 1916, 1970, we did 350 Whipples a year. Now, it dropped down in 18 because I stopped operating that year, and so the numbers have dropped. But in the next couple of years, I'm sure they will rebound. And it's like any operation, the more you do them, the more you understand the anatomy better. You can anticipate complications, intervene earlier. So volume has made a huge difference in this operation and its outcomes. The biggest difference is that in the past, the 25% mortality was because the pancreatic jejunostomy leaked. It caused an abscess. The patients became septic and died, or else it eroded into a vessel and they bled to death. Now, it doesn't matter how you do the anastomosis. You can do invagination, you can do duct to mucosa, you can use a stent, you don't have to use a stent. The important thing is to drain it. And we put closed suction drains on top and underneath the anastomosis. Now, putting drains on an anastomosis increases the leak rate. So we have a fairly high leak rate, but it's all controlled out these drains. And patients don't get septic, they don't erode vessels, and they don't die. And I think well-drained anastomoses is the major reason that the mortality has dropped precipitously for this operation. Now, who to do this operation on? We had to work out during the 90s and early 2000s. This lady is 103 years old. Now, some have said, even though she's 103, she looks in better shape than her surgeon. But at the time, we wondered how, there must be an age limit. And maybe 100 is the age above which you shouldn't do a Whipple. But then her daughter, her granddaughter, and her great-granddaughter came to see me and said she's still vigorous, she's still active. They wanted her operated on, so we did a Whipple on her, and she was in the hospital for about 2 weeks and was discharged with pancreatic cancer and did well. Now, from about the middle 80s, when I became chief, to 2017, we've done 450 patients over the age of 80, 22 over the age of 90, and 1 patient who was 103 that I just showed, with a mortality, a hospital mortality of 2.7%. So you can operate on any patient, any age group, as long as they're healthy enough so that the anesthesiologist says we can put this patient to sleep and wake them up in 6 hours and they're going to be fine. Now, from 1969, when I finished my training, to 2012, I did 2,000 consecutive pancreatic duodenectomies. Now, I like to say that, and Rushlin knows this because he visited our unit in 2003. I did the first Whipple myself from beginning to end. The next 1,999, I assisted a year 4 resident, a year 5 resident, or a fellow. I was there the whole case, but I assisted my assistant in doing the procedure. So you can do this complex operative procedure in trained residents and still get excellent results. You can see the mean age was 67. The number of patients over 80 was 203, so 10% of this series was over the age of 80. 7 were over the age of 90. A few more males than females. Now, this is just to show the difference that has occurred in the pathology sheets. This is the full pathology report from that first Whipple, and they talk about looking at 2 lymph nodes and the fact that they think it arose from the ampulla. So it was a very limited, insufficient pathology report, and the pathologists have progressed a long ways as well as the surgeons, and now we get very detailed reports. You can see in 1960s, the year I finished 69-70, my training, I only did 1 Whipple. In the 1970s, I was doing mostly research, so I only did 2 Whipples. And then in the 1980s, when I took over the department, I started doing a few more, a lot during the 1990s, and then mostly during the 2000s. When we look at the first 1,000 and compare it to the second 1,000, the second 1,000 was a little older. There were more patients over the age of 80, and the comorbidity index increased, but fairly similar. The 30-day mortality of all 2,000 patients was 1.4%. The hospital mortality, or 90-day mortality, was 1.6%. So again, helping residents or fellows doing this operation, teaching them how to do it, you can still get excellent results. So it's no reason not to use trainees to learn to teach this operation. Now, when we look at the 31 patients that died, it's a small number out of 2,000, but when you look at them, 16 died of sepsis. And I would like to think that we should have been able to rescue more of those patients, those 16 patients. So that should have been perhaps less. In bleeding, patients really should not die from a Whipple procedure from bleeding. We had 3 patients who died from intraoperative blood loss. And so, again, the number that died from bleeding should have been decreased. So 31 is a few out of 2,000, but it probably should have been even less. Now, when we look at the 31 patients who died and compare them to the 1,969 patients who survived, those that died were older. There were a higher percentage that were over the 80, and the comorbidity index was higher. So they definitely were a higher risk group. When you look at the patients under 80 and over 80, under 80, the hospital mortality was 1%, over 80 it was 4%, and the morbidity was also higher. So elderly patients carry a higher risk, but it's still low enough that I think they should not be denied the opportunity of a curative operation. Now, the morbidity remains high for this operation, and for any complication, 45% of patients developed a complication. But they're no longer life-threatening complications. The most common complication, delayed gastric emptying, the need to reinsert a nasogastric tube within a week. 23%, that's the most common complication. Postoperative pancreatic fistula remains high, 16%, but it's principally because we put the drains right on the anastomosis, and it no longer is a life-threatening complication. And then wound infections, 11%. Fortunately, we have that down to about 4 or 5% in the last couple of years. Pancreatic postoperative fistula for pancreatic adenocarcinoma with a hard, firm gland and a big duct, 8%. In the other 1,099 patients who didn't have a pancreatic adenocarcinoma, but had a soft gland and a small duct, the incidence of pancreatic fistula, of course, is higher, 20%. And again, the important point is not that a fistula develops. The important point is that the fistula is controlled. And if you put drains in front and back of the anastomosis, the fistula, if they leak, it's going to be controlled and it's not going to be a life-threatening complication. Now, if you're in a hospital, that does a high volume of Whipples, you have to have a very good interventional radiology lab, IR, interventional radiology, or a cath lab. Because you can see 5% of our patients required percutaneous drainage of a collection. Those are patients that would have had to have been re-explored had we not had a good interventional laboratory. Pancreatic bile leaks are uncommon, but when they occur, they can be troublesome. But if you have a percutaneous biliary drain put in, it immediately controls it, and that's needed in about 1%. Now, delayed bleeding. If a patient bleeds following a Whipple within the first 24, 36 hours, the treatment is to immediately take them back to the OR to control it. But if it's 5 or more days later, that's called delayed bleeding, and that usually is from a false aneurysm. And those patients need to go to the cath lab and have angiography and have the false aneurysm embolized. So it's 8% of our patients make a trip to the interventional lab post-op, so it's essential to have a very good interventional laboratory. Now, delayed bleeding is an infrequent complication. You can see in the first 1,000 it was 1.5%, it was about the same in the second, so it's infrequent. And if you're only doing 60 or 70 Whipples a year, you may go 2 or 3 years without seeing one. But when you're doing 350, you have 1, 2, 3, or 4 a year. And you can see, even though it's an infrequent complication, the mortality of it is very high. And we've struggled in how to manage them. We've endoscoped them for a while first. We've gotten a CAT scan first for a while. We've finally decided when a patient develops a delayed bleed, 5 or more days after the Whipple, they should go immediately to the interventional laboratory and have them do an angiogram, identify the false aneurysm, and embolize it. So we've struggled, we've done a lot of different things, but now we've finally decided they all go to IR, interventional radiology, immediately. Now, 3.5% of the patients have required a second operation. That's a fairly low number, and you can see the most common cause is for a wound problem. The second most common cause was delayed bleeding, but we wouldn't do that now. Delayed bleeding is not well managed intraoperatively. It's best managed by embolization in a interventional radiology. So that group no longer exists. And for a PJ leak, 12 out of 2,000. So 3.5% need to be reoperated on, but the most common indication is for a wound problem. Now, the results. These are the results from the past. If you have a duodenal or an ampullary cancer, you have about a 50% chance of 5-year survival. With distal cholangiocarcinoma, it's about 30%. And for adenocarcinoma, the head of the pancreas, it's 20 to 25%. Those are the figures historically from our institution. Now, for carcinoma of the head of the pancreas, if they're node negative and margin negative, they have almost a 50% 5-year survival. So this suggests that a tumor marker, similar to PSA for the prostate, but it's probably too sensitive for the prostate, but we need a PSA for pancreatic cancer so that we can identify these patients earlier and can operate and do the Whipple before they've spread to the nodes or before you can't get a negative margin. And in that case, there's about a 50% 5-year survival, so it's much improved. Now, doing a lot of volume of Whipple procedure, initially we were proud of that, we like to brag about it, but there've got to be some advantages. And one of the advantages is we've been able to do a series of prospective randomized controlled studies in one institution and do them fairly rapidly because we have a high volume. We've done pancreatic jejunostomy versus pancreatic gastrostomy, octreotide, no octreotide. We've done a lot of prospective randomized studies. Perhaps the most important was a standard pylorus preserving Whipple versus hemigastrectomy and retroperitoneal dissection, sort of a super Whipple. And that study, as most of the studies, turned out negative. There was no advantage in our hands of doing an extended radical pancreatic duodenectomy over a standard one. So doing these prospective randomized studies have demonstrated to us in the early years, the 80s, 90s, and early 2000s, how to do the procedure. In addition, it's attracted the largest group of clinician scientists, basic scientists interested in pancreatic cancer, certainly in any unit in the United States, maybe in the world. And we now have a $25 million of active direct support from the NIH to study pancreatic cancer, and we have an endowment of $35 million. And these are some of the people listed who have been active in the research in pancreatic cancer. I'll just point out two names. In the first column on the left, almost down at the bottom, is Ralph Ruban. He's a pathologist at Hopkins, and he's worked out most of the pathological descriptions of pancreatic cancer and PANCREATECTOMY. And he's the most frequently referenced investigator in the world in pancreatic cancer. And over in the right-hand column, the third from the top, Bert Vogelstein, is the scientist who worked out all the steps that take from a benign colon polyp to dysplasia in situ and cancer in the colon. He's the one who's worked out all those steps, and now he's concentrated on the pancreas. So again, attracting large volume has attracted a lot of clinician scientists, and basic scientists working on this disease. Now again, 2,000 consecutive pancreatic duodenectomies in an academic institution, a teaching hospital. I show this slide again just to emphasize you can train young surgeons how to do this operation, doing large volumes, and still have excellent results. Now, in addition, I'm not going to go over these names because I think most of them you won't know. But these are the individuals who trained at our institution on the Whipple operation principally, and have gone around the United States and become chairs of departments and have concentrated on pancreatic cancer. So the Johns Hopkins Hospital has sort of seeded the United States all over from California to New England of pancreatic surgeons who continue to lead the way in this disease. Now, the future. You can see that we did the first laparoscopic Whipple at our institution in 2005, and I think have done over 450 in the interim. We did the first robotic Whipple in 2012, and now have done about 150 of them. And again, for any young surgeons in the audience, if you want to be doing Whipples 10 years from now, learn how to do them minimally invasively. Learn how to do them laparoscopically or robotically, because 10 years from now, I think 80% of these operative procedures, if not higher, are going to be done minimally invasively. Now, neoadjuvant therapy has in the last few years become very prominent. And neoadjuvant therapy with FOLFIRINOX, first demonstrated by the French in an article that appeared in the New England Journal some years ago, in patients with stage 4 pancreatic cancer, demonstrated its effectiveness. And we started using it as adjuvant therapy. And now in our unit, we feel everyone should receive neoadjuvant therapy, not only borderline resectable, vascular invasion, but patients who are clearly resectable with small lesions not involving any of the vascular structures. We think everybody should receive at least 8 cycles of FOLFIRINOX, Gemzar, Abraxane, or GTX before they're explored, because their effectiveness in converting borderline resectable and locally invasive patients to resectable is very high. The true, in many, many institutions throughout the United States and throughout Europe, and I'm sure here in Russia, have demonstrated that if the disease stays stable or shrinks, they should be explored. Because even if the disease doesn't shrink, the borderline resectable and locally invasive patients can be resected, and often the disease that's next to the superior mesenteric artery, where you usually have to peel it off, often is desmoid reaction, and it's cancer that no longer is alive. So converting borderline resectable and locally invasive patients to resectable, I think, is clearly been demonstrated by many, many units throughout the world. Immunotherapy to date has really not been successful. We have a vaccine that was produced by Liz Jaffe, a basic scientist at Hopkins, that we've used for the last 15 years that we think is effective. But true immunotherapy, like has been demonstrated for melanoma, some lung cancers, renal cell carcinoma, has not been effective for pancreatic cancer, but it will be. And sometime during the next decade, I'm sure immunotherapy will be part of our therapy. Now, circulating tumor cells in patients with pancreatic cancer can now be clearly demonstrated. And in our series, when a patient has a Whipple and is followed with blood samples looking for circulating tumor cells, the circulating tumor cells can be identified well before a local recurrence is demonstrated on CAT scan. And in addition, we've just received a $50 million grant, $10 million a year for 5 years, to detect circulating DNA. Circulating DNA in patients with pancreatic cancer can be identified long before the lesion is symptomatic or is demonstrable on CT or MRI. So we're just starting this study on a population of patients in central Pennsylvania that's stable, all belong to the same health system. And it's over a 5-year period to see how many patients we can diagnose with circulating DNA before it's evident on imaging. Now, we don't know yet what we're going to do with those patients when we identify them, because if they have a normal CT, what do you do? What part of the pancreas do you resect? Do you routinely resect the head, because that's where most of them are? Do you take the whole pancreas out? That hasn't been worked out. But as a test, as a circulating marker, DNA may provide some benefit, some real benefit. Now, I think this is, I don't think I have a pointer, but the purple line on this represents, I think, about 800 patients who've had a Whipple for pancreatic adenocarcinoma with the typical 20% 5-year survival. Then we took 300 patients and gave them neoadjuvant therapy. These are all patients borderline resectable or local invasion. And about 10%, 31 patients, we went ahead and resected, and there was no tumor left. There were no lymph nodes with tumor, and the primary was gone. And those patients have between the 60 and 70% 5-year survival. Now, the rest of the patients either had a partial response or no response, and these patients had the same 5-year survival as our standard patients from the last 10 years or so. And 10 years ago, we probably wouldn't have operated on those patients. But with neoadjuvant therapy, they were operable, and they have the same survival as patients who had resectable tumors to begin with. So we now recommend to everyone, to every institution, that patients should receive neoadjuvant therapy before they're operated upon, whether they're clearly resectable, borderline, or locally invasive. Now, it's too early. We've just started this protocol about a year ago, so it's too early to say how it's going to work out. But I hope it's going to give us a major step forward in 5-year survival. Now, after the first 2,000, which ended in 2012, I've done 400 more Whipples until I stopped just about a year ago now. I'm 82 years old. I stopped when I'm 81. So surgeons, don't stop too early. Keep going. It makes your wife happy to have you keep working and out of the house, and it keeps you happy also. So from the first 400 patients I did in the early 1980s and 1990s, compared to the last 400 I did in 212 to 218. First of all, they're about the same age, a little older now. The number of patients over the age of 80, a few more, but in the same range, and the ratio between Whipples and totals about the same. Delayed gastric emptying, amazingly, was about the same, 72 patients, this isn't percent. Postoperative pancreatic fistulas was about the same. Wound infection was about the same. Bleeding was about the same. And amazingly, the hospital mortality was the same. So when I first aimed our department in the middle 1980s towards doing the Whipple, and it had in our hospital and every other hospital in the United States a 25% mortality, we started doing large volumes, and all of a sudden, in the blink of an eye, the mortality dropped from 25% down to 1%. And of course, in the last 400 I did, it was the same. Now, why was that? Why, in our institution, as soon as we started focusing on that operation, why were the results almost immediately much, much better? Well, because we started doing high volume. We did some studies in the state of Maryland, the state where Baltimore and the Johns Hopkins Hospital resides. And early on, we became a high-volume hospital. And to be a high-volume hospital in the United States, you only officially need to do 15 Whipples. We think the number should be about 50, but it actually is only 15. And the mortality at our hospital, compared to the other 45 hospitals in Maryland, where they did less than 15, our mortality was 2, 3, 4% at that time. And the mortality in the other 45 hospitals was up around 15 or 20%. So we convinced insurance companies that they should send the cases to a high-volume hospital. The mortality was going to be less, the morbidity was going to be less, the length of stay was going to be shorter. And so we very quickly became a very high-volume hospital. We're the highest volume hospital in the United States, and it came about because we demonstrated, we were the first to demonstrate that in a high-volume hospital, the mortality, morbidity, length of stay was all less. And of course, insurance companies like length of stay being short because it costs them less money. So centralization of high volume, of high-risk, complicated operative procedures is something that I believe in, and I think most institutions in the United States now believe in. Adequate drainage of the pancreaticojejunostomy, that is key to decreasing the morbidity. And Halsted in the United States and Coker in Europe were the first to develop the principles of careful hemostasis, careful handling of tissues, gentle avoiding dead space, etc. And of course, we were believers in that because Halsted was the first chief of our institution. So pancreatic surgery, I think, has made great strides from the middle 1980s when people in the United States, throughout Europe, throughout Asia, started becoming reinterested in the Whipple procedure in pancreatic cancer. and we've come a long way. But I think in the next decade, it's going to be a very exciting period. And I think the 5-year survival of patients with adenocarcinoma is going to make a giant leap. And I think part of that is going to be giving neoadjuvant therapy to all patients who are surgical candidates. So in closing, I'd like to again thank Professor Katkoff for the opportunity to come and address this group of surgeons. And later on, we'll be happy to enter in any discussion. Thank you very much.